Hi, I am Krisha Marie Mantilla, a third-year BS Biology student. This is a case study presentation in Salmonellosis. Today, I am going to present a case study on liver abscess associated with Salmonellosis in an HIV-positive man. First off, let's go over the summary of the case study. A case of liver abscess caused by a non-HIV enteritidis serovar of Salmonella enterica in a 31-year-old HIV-positive man was reported in Brazil. The patient just recently returned to Sao Paulo, Brazil from a trip in the Caribbean. Percutaneous catheter drainage and antibiotic treatment resulted in good clinical and radiological response. This has been the first culture-proven case of liver abscess associated with non-HIV S. enteritidis infection in an HIV-positive individual in Brazil. Before we dig deeper in our case, let's talk about salmonellosis first. We can't ever talk about salmonellosis without even discussing poultry products, especially eggs. Eggs are the most common carriers of salmonella. And if I may ask, how do you like your eggs? Boiled? Scrambled? Sunny side up? Or do you add it raw to your smoothies? If you like it raw, then congratulations! Salmonella infection is waving at you. But wait, don't fret. This is not always the case. So stick with me and learn the basics of salmonellosis, including its definition, its causative agent, mode of transmission, clinical manifestations, and treatment. Salmonellosis is actually a common foodborne bacterial infection in the intestinal tract, caused by the bacterium Salmonella enterica. S. enterica is a gram-negative and non-spore-forming bacillus that has more than 2,500 serovars. Diseases in humans and domesticated animals associated with S. enterica are commonly caused by the typhoidal and non-typhoidal serotypes of the bacteria. In this report, the focus is on the non-typhoidal enteritidis serovar of S. enterica as a causative agent of salmonellosis. In fact, the Centers for Disease Control and Prevention estimates that Salmonella bacteria caused about 1.35 million infections, 26,500 hospitalizations, and 420 deaths in the United States every year, with which food is the primary source of majority of these illnesses. So how is Salmonella acquired? Humans can acquire Salmonella via the fecal-oral route, which involves the ingestion of contaminated food and water, such as poultry products, dairy products, and fresh produce. Also, it can be acquired through direct contact with infected animals such as birds and pigs, and rarely through direct and indirect contact of an infected person. Traveling to areas endemic of salmonellosis also increases the chance of a person to be infected. Once acquired, it will take an average of about 12 to 72 hours or longer before the onset of symptoms occurs. Infection could take a few days or several weeks, in which salmonellosis is deemed to be communicable. Clinical manifestations of salmonellosis include gastroenteritis, which is an illness caused by an inflammation in the digestive tract. This is manifested by headache, fever, diarrhea, abdominal pain or cramps, nausea or vomiting. In rare cases, bacteremia, which is characterized by the presence of bacteria in the blood, can occur. Also septicemia, which occurs when the bacteria multiplies in the blood and which could further lead to organ infection. However, healthy hosts can recover within a few days even without specific treatment. Once ingested, Salmonella bacteria survive and pass through the highly acidic environment of the stomach onto the intestines, in which they can persist for long periods of time. These bacteria attach and invade the inner lining of the intestinal tract, either through its fimbriae or pili. This involves the binding of specific receptors on the epithelial cell surface. Subsequently, invasion of the intestinal epithelium occurs, which involves pinocytosis of the organisms. The bacteria proliferate within the epithelium and lymphoid follicles. The organisms then spread into the mesenteric lymph nodes and throughout the body through systemic circulation. Virulence of the strain and immunity of the host play a part in how salmonella infection progresses. Usually, healthy hosts can only experience minimal symptoms such as vomiting and diarrhea, while immunocompromised individuals may suffer bacteremia, septicemia, or worse, a localized infection. So, how does the body respond to this bacterial invasion? The bacteria that spreads throughout the body through systemic circulation are taken up by the cells in the reticuloendothelial system. The RES control the spread of the bacteria. Phagocytic cells in the circulation and in tissues constitute the RES, which involves the monocytes of the blood, macrophages in connective tissue, lymphoid organs, bone marrow, bone, liver, and lungs. Additionally, the epithelial cells in the intestine synthesize and release pro-inflammatory cytokines. These evoke an acute inflammatory response, causing damage and ulceration in the intestines. Fever, chills, abdominal pain, leukocytosis, and diarrhea are symptoms induced by this inflammatory reaction. Basically, the host responds to the bacterial invasion by activating cellular and humoral immune responses and through the actions of nonspecific phagocytes. Also, when the bacteria invades the intestinal tract, our immune system responds by producing oxygen radicals to kill the bacteria. Although some Salmonella bacteria are killed by this response, many more can benefit from it. The oxygen radicals create a sulfur compound called tetrathionate, which Salmonella are able to use instead of oxygen for respiration. Stimulating the host to produce tetrathionate enables Salmonella to breathe in the intestine. Now on to our case presentation. This is a report generally about how Salmonella infection becomes serious illnesses when it occurs in immunocompromised host. The case study involves a 31-year-old man who consulted to a hospital in Brazil with concerns of having fever daily for 4 weeks, moderate pain in the right upper abdomen, and a weight loss of about 5 kilograms. 2 months prior to this, the patient was diagnosed with HIV, and he just recently returned to Sao Paulo, Brazil from a trip in the Caribbean. And during his travel, the patient admitted of having fever and dysenteric diarrhea for 5 days. Ciprofloxacin was administered for a week, which relieved his symptoms, although the patient continued experiencing intermittent fever. Additionally, the patient recalled having eaten fresh lettuce and tomato during his stay in the Caribbean. It is noted that the Dominican Republic is an endemic area of Salmonella infection, while Sao Paulo, Brazil is non-endemic for Salmonellosis. Initial examination revealed a body temperature of 38 degrees Celsius, a pulse rate of 110 beats per minute, and a blood pressure of 110/70 mm mercury. A tender liver palpable 3 centimeters below the costal margin of the abdomen was also observed. The hemoglobin was 8.3 grams per deciliter, white blood cell count of about 11.7 times 10 to the 9 per liter, polymorph 73%, band forms 5%, lymphocytes 13%, and monocytes 6%. The cell count for CD4 plus cells was 265 cells per microliter. The sedimentation rate was recorded to be at 65 mm per hour, and alkaline phosphatase was 558 IU per liter. Total serum bilirubin and transaminases were normal. The differential diagnosis was an infection due to either Entamoeba histolytica or Salmonella. The basis for this is the fact that the patient has recently traveled to Dominican Republic, which is an area endemic of Salmonella infections. Also, the patient exhibited fever and diarrhea, which are common symptoms of the infections caused by these two bacteria. And the fresh lettuce and tomato the man had while traveling was suspected to be the source of the pathogen. And lastly, also due to the detected liver abscess, which is a sign of a localized infection. After further examinations, the chest radiograph showed no abnormalities in the lungs or pleural space, although the right diaphragm appears to be elevated. Serology results were negatives for Salmonella typhi and Salmonella paratyphi, while serology for Entamoeba histolytica was not performed. No growth of cultures were discovered in blood and urine, while a stool culture was positive for Salmonella Enteritidis. Additionally, one large abscess in the right lobe of the liver was found through a CT scan measuring 17 by 12 centimeters. From these results, it is therefore concluded that the liver abscess detected in the patient is because of an infection brought about by the Enteritidis serovar of S. enterica. On the third day of the patient's stay in the hospital, no clinical improvement was observed, so a non-guided needle aspiration of the liver abscess was performed, producing 200 ml of brown fluid. Also, a percutaneous catheter drainage was performed. 2 days after, about 700 ml of purulent material was drained, and culture revealed the presence of Salmonella Enteritidis. The patient was prescribed with intravenous ciprofloxacin in place of ceftriaxone and metronidazole therapy. Ciprofloxacin is an antibiotic used to treat serious infections, especially when other antibiotics have not worked. The liver abscess had significantly decreased in size as shown on the ultrasound on day 12, with the patient still experiencing fever and mild abdominal pain. The patient has no fever and was asymptomatic a week after this. On day 28, the patient was discharged and was prescribed with oral ciprofloxacin to be taken for 3 months. 5 months after diagnosis, follow-up checkup revealed a CT scan of liver with no signs of abscess, and the patient presented no complaints. So what important points can we get from this case? First is that immunocompromised individuals have a high risk of acquiring localized infections due to Salmonella. Immunocompromised individuals like HIV patients are susceptible to Salmonella infections 20 times higher than the general public, and the occurrence of bacteremia is highly likely as compared to immunocompetent individuals. In highly susceptible individuals, Salmonella infection could lead to bacteremia, which is considered the most common manifestation of Salmonellosis in HIV-positive patients, and is deemed to be an AIDS-defining illness given that bacteremia is recurrent in the patient. Patients with bacteremia are faced with the bacteria's potential to proliferate in tissues or organs that can lead to serious infections. Second, although liver abscesses associated with Salmonellosis are extremely rare, non-type Salmonella should be considered in the differential diagnosis for HIV-positive patients with a single liver abscess. About 25% of the cases of Salmonellosis in HIV-infected patients were reported to have experienced organ infections, specifically in the urinary tracts, lungs, bones and joints, vascular system, central nervous system, abdominal cavity, and soft tissues. However, liver abscesses are extremely rare. In fact, this has been the first culture-proven case of non-typhi Salmonella liver abscess in an HIV-infected patient in Brazil. And lastly, the likelihood for adults with Salmonella intra-abdominal abscess to be treated is high with combined surgical and clinical treatment. Performing aspiration with percutaneous catheter drainage and antibiotic early on HIV-infected individuals with liver abscess associated with Salmonella seems to determine good outcome. I would like to end this presentation lightly with a joke about Salmonella, but it should be kept a secret. I'm afraid it might spread around. Well, anyway, thank you for listening up to this point. Have a good day.